thank you all for coming to Pasadena. We really appreciate you visiting, and we're quite confident that you will not be getting food poisoning in any of our restaurants. I just want to welcome you here, and I want to introduce you. We are one of only 3 city health departments in the state, along with Long Beach and Berkeley, and we're nestled inside of the county of LA, so we work very well with our partners at the county, and we really appreciate their support in everything that we do. I'm here to introduce one of my favorite people in the country, which is the mayor of the city of Pasadena. If you've not met the mayor of Pasadena, you've not really met a good American mayor yet. He's an amazing man, and he does great work. He supports our health department, and he isn't just concerned with how our government runs here locally, he really understands public health. He's helped me in initiating programs to tackle violence, especially youth and gang violence, as a contagious disease. He's helped with us looking at how we can get fresh fruits and vegetables into the hands of our residents, especially those that have the least access to it. And he's worked diligently with us around the ideas of how we can increase exercise and getting people active in the city. So without further ado, I want to introduce to you one of my favorite people in the world and the mayor of this great city, Mayor Bill Bogard.
Thank you, Dr. Walsh. It's a pleasure to be here and to join with others in extending a cordial welcome to you, to thank you for being here in Pasadena for this important conference. Pasadena takes pride in the level of work that goes on here and the ability to attract sophisticated and highly educated groups like this to our conference center. With the organizations that have already been mentioned, Caltech and Jet Propulsion Laboratory and our major museums, the Norton Simon and the Huntington Library, we think that we have a lot to offer, certainly for enjoyable visits on the part of tourists, and I hope your time here includes some time to enjoy our cultural institutions as well as our great restaurants. But it also creates a climate of thoughtfulness and strategic planning for the nation and intellectualism that in which we take great pride. So you're contributing to something that is important to our vision of ourselves here in Pasadena, and I thank you for it. I've learned a little bit about your work, the Council of State and Territorial Epidemiologists, and how important it is, how scientifically based it is, how it is based on the facts of the research that you do and that you work with. I have notes that allow me to tell you about your work, but I've decided to set those aside since you know your work better than I do. But I can say that I've learned in preparing for this appearance about the scope of your work, the extent to which this group represents a national organization, and some of the techniques that you use to accomplish your goals. So I'm duly impressed and grateful that you're here. On the tourist side of Pasadena, I do hope you have time to enjoy some of our offerings within walking distance. In addition to the 100 restaurants in Old Pasadena that are readily available to you, we have the Norton Simon Museum, which is world-renowned, the Pacific Asia Museum, which is one of the preeminent Pacific Rim museums specializing in Asian art. We have the Pasadena Playhouse and the theater on Mentor Court. Wonderful cultural opportunities. Across the street there's a theater with 10 screens, and while I don't want to distract you from your important work, I do want to say that you'd be welcome to slip over and check out whether Pasadena's offerings are of interest to you. And I hope that those who have not been to Pasadena before, well, I hope all of you return to Pasadena and have good times here in the various ways that Pasadena has to offer. I was going to say at the outset, and I'll close with this, that when Dr. Eric Walsh extended an invitation to me to be here today, I know he was acting on behalf of the council. It didn't take me a second to say, of course I'll be there, because of my great admiration for Dr. Walsh and the operation that he has composed as an offering to this region of California, to the city and to the region, through the Public Health Department. The Public Health Department in Pasadena has never had a broader scope of activity. It's never been more effective in delivering services. It's never had a stronger staff. So from my point of view, as mayor, who wants to promote the strengths and the opportunities in the city for the people who live here, who live nearby, and who visit, Dr. Walsh is a hero to me, and I'm always happy to say yes to him when I can cooperate with him. I like to bask in glory, and from my point of view, Dr. Walsh creates that kind of atmosphere. Once again, thank you for being here. Have a wonderful time in Pasadena, and I hope that when you finish your work on Thursday, that you will feel that you've not only spent your time well in terms of your professional activities and the activities for the coming year in your field, but that you've had a good time and a fond memory of this great city. Thank you for being here.
Thank you very much, Mayor. That was really heartening. And don't forget, there's also a comedy store here as well. So if you want a good laugh, what's the name of the comedy store, Eric? The place that's some comedy store around here that's sort of fun to go to. You know, we might need to break it up and laugh a little bit after some of the serious things that we do here. But talking about things that are not so serious, it's now my pleasure to present some awards. And one of them is the Distinguished Leadership Award. And this is the third annual award for distinguished leadership of the CSTE epidemiologist that was established by the Executive Board to recognize the efforts of a current CSTE subcommittee chair, liaison or consultant who provides exceptional guidance, leadership, and dedication to the organization over the past year. The work, as I said before, the subcommittee chair sometimes requires many hours, facilitating conference calls, herding together all the feral cats of the subcommittee, having meetings, emails, beseeching people to carry out the tasks instead of doing it themselves, you know, working with the council, working with the CC, ADC, CSTE cooperative agreements, and I want to thank the membership for actually submitting so many outstanding nominations to recognize the dedication of the leaders that are in our organization. And one such leader is Dr. Christine Hahn. Dr. Christine Hahn is known statewide for her common approach to often challenging situations, has wanted to help as many people as possible since she finished her training as an EIS officer with the CDC in 1995. Time flies, doesn't it, huh? And she realizes that she really enjoys helping people enjoy healthy, happy lives now as well as in the future. That feeling led her to accept the position as Idaho State epidemiologist in 1996, and she continues to be the go-to authority for an array of healthcare professionals in the state, as well as the state's public health districts. Her favorite part of the job is being able to help busy medical practitioners to help them get the tools they need to make their patients be successful and lead happier lives. Her work overseeing the Idaho Refugee Screening Program has helped her to provide coordination and standardization of the screening processes between clinics throughout the state in the last 2 years. She's also been instrumental in aligning the immunization requirements with the CDC's Advisory Committee on Immunization Practices, such that the children in Idaho are starting school with the recommended panel of vaccines. As the state's TB controller, she's advised and supported physicians treating and managing the disease. Christine attended the medical school at Michigan State University, go Spartans, and completed a residency in internal medicine at the Mayo Clinic's Graduate School of Medicine. She then did an ID fellowship at Duke University Medical School, then on to EIS, and then off to Idaho. She has served on the CDC's Advisory Committee for the Elimination of Tuberculosis until 2012. She was recently named the Medical Director for the Division of Public Health with oversight of the Bureau of Communicable Disease Prevention and the Idaho Bureau of Laboratories. She did serve as the president of CSTE in 2004 through 2005. She's the organization's liaison to the CDC Advisory Committee on Immunization Practices, and really she's the only one that I know of subcommittee chairs that writes great minutes to send to everyone on what she actually hears there, which is a great accomplishment in and of itself. She serves on many infection prevention committees in Idaho and Boise, and is on the board of Idaho's Immunization Policy Commission. So with that, it's a great pleasure to announce the 2013 Distinguished Leadership Award to Chris Hahn for her exemplary leadership. So Chris, come on up. Thank you, Chris. See, so any one of you could be her if you just work really hard on a subcommittee. So remember, those are really important placards. So now I want to move on to the Distinguished Partner Award. And this is the third annual CSTE award to recognize an individual or organization that has made or makes significant contributions to CSTE in the work of our membership. Dr. Stephen B. Thacker was a dedicated, prolific champion of applied epidemiology and evidence-based public health. Dr. Thacker died on February 15, 2013, at the age of 65. Throughout his nearly 37 years at the Centers for Disease Control, Dr. Thacker was a preeminent leader of public health science and an advocate for professionals who practice that science. He held various leadership positions across the agency, including the Director of the Office of Surveillance, Epi and Laboratory Services, the Director of Workforce and Career Development, and the Director of the Epidemiology Program Office from 1989 to 2004. During his tenure at CDC, Dr. Thacker was a steadfast champion of epidemiology, public health surveillance, and other analytic methods for use in public health. He fostered collaborative efforts to identify, introduce, and disseminate innovative scientific methods and technology to enhance public health practice at CDC, both nationally and internationally. For example, he oversaw the development of the National Electronic Telecommunications System for surveillance, the first integrated system that allowed states to use their own information systems or supported them in their use of EpiInfo for national notifiable disease surveillance. He was a committed steward of many other CDC's flagship programs that are critical to CSTE and its members. Every week for more than 20 years, he reviewed articles to be published in the CDC's Morbidity and Mortality Report, affectionately known as the MMWR, a critical vehicle for disseminating practical public health information to the field in the mid-1990s. He was also instrumental for the initiation and ongoing development of EpiInfo software, a workshop we just had recently on Sunday. And he enthusiastically embraced and facilitated the development of the Guide to Community Practice Services as a foundation for evidence-based public health. In addition to his scientific contributions, Dr. Thacker supported public health through his mentorship and influence on young scientists. And I know a lot of us in the room felt that mentorship. He was especially known for his extraordinary dedication to the EIS service program, another program critical for the development of epidemiological capacity in the country. He was committed to its quality, personally interviewing applicants and reviewing applications each year, and he ensured the expansion of the program to include the women and minorities in each succeeding class. He could remember the background of every EIS officer admitted during his watch, and he never missed a day at the annual EIS conference, and I know that for sure. He oversaw the expansion of field-based assignments and developed the Career Field Epi Field Officer Program, or CFO, known as CFO after 9/11. and nearly half of the county's state epidemiologists are graduates of the EIS program. While his impact through his social DNA, as Dr. Bill Fagey defined it, is immeasurable, the numerous comments that are posted on the Thacker family website by EIS graduates and other fellows attest movingly and substantially to his legacy. Dr. Thacker has authored or co-authored more than 240 papers and textbooks and has been the editor of many scientific papers and journal supplements on a broad range of public health topics. He's also known for his extensive knowledge of CDC history as exemplified, and this is a great review article to read, in the American Journal of Epi Supplement, where he co-edited an article describing over 4,000 epidemic assistant investigations performed throughout the world by CDC's officers and staff from 1946 to 2005. And through his many publications and mentorships, his influence on public health practice will continue well into the future. Dr. Thacker served as a source of inspiration and motivation to all that he met through his integrity, his dedication, and his passion. And having begun his career at CDC in the field, he was always a strong supporter of field-based epi. He always wanted to improve the quality and quantity of CDC's epidemic assistance provided to the states. Regardless of whether field-based epidemiologists were graduates of the EIS program, CSTE members always knew they could consult Dr. Thacker regarding a challenging epi problem and get a very thoughtful, unbiased response. He will be greatly missed. CSTE presents the 2013 Distinguished Partner Award posthumously to Dr. Stephen Thacker. And if Denise Koo would please come forward to accept this award on the behalf of his family. Let's give a big hand for Dr. Stephen Thacker.
All right. So Lorraine told me to keep it short, because as usual, we've got a lot going on at CSTE, but I think with Steve's 37 years, I will take a few minutes and I will make it short. I am, of course, very honored to accept this award on behalf of my dearly beloved deceased boss of 15 years. He's a very rare breed at CDC, as you can see, a cross-cutting, purebred scientist. There's not that many who can do epi in so many different fields. I'm not going to repeat the long, long list of accomplishments, because then we will be here all day. A couple just comments that I wanted to do to make, to give the sense of Steve as a person. You know already that he loved the agency and he loved public health. He was always the first one in the parking lot, 7 a.m., the last one to leave the parking lot at 7 p.m. Our joke at CDC, those of us who are younger than Steve, was always that we would leave CDC before he did, because he would die at his desk. Unfortunately, that did happen way sooner than it should have. But other aspects of Steve, in addition to the fact that he really so much cared about all of us and mentoring officers and fellows and epidemiologists, and his legacy lives on, is that he was, believe it or not, and you may not know this, he could be incredibly chatty. He loved movies. You could always talk to him about the latest movie that he'd watched. He loved sports, and especially girls basketball. He had coached it ever since his girls were kids, and he never stopped coaching girls basketball up until this last fall. In fact, even if he were alive, I'm not even sure that Steve would be here to accept this award. He would probably still have me do it, because the CSTE meeting so often coincided with a girls' basketball camp that he was utterly dedicated to. This is why you haven't seen him at very many CSTE meetings over the last few years. It's the only thing that always overrode work, is this girls' basketball camp. So that's just one other thing I wanted to say. And really, I owe so much to Steve, because through Steve, I have found my niche as a cross-cutting epidemiologist in the area of workforce. And I'm not planning to leave it, so I don't know who's applying for his job, but it's not me, because I really, really believe strongly in the need of strong workforce, and for CDC to have rigorous approaches to workforce. So I'm looking forward to contributing to his legacy in that way. So the last thing I will say is the message from the Thacker family is thank you all for the recognition of our beloved husband and father. Steve firmly believed in your mission to use the power of epidemiology to improve the public's health. We appreciate the continued comforting words or act such as this for Steve's legacy of invaluable service to public health. Each recognition warms our hearts, and we thank you. So I want to ask the audience, those of you who don't know Steve, to go to the www.teamthacker.com website, where you will see various videos that we have done in tribute to Steve, testimonials, and for those of you who didn't have an opportunity to say goodbye to him, please leave a testimonial, a comment on that website. The family, from whom he very much protected their private time, will really appreciate hearing from you all about Steve's legacy. So thank you very much.
I want to thank Denise for coming, and I also want to mention, because it's not in your book, that Denise will be leading a roundtable discussion at 7:15 Wednesday morning in room 214, so that's Wednesday, room 214, titled Public Health and Healthcare Integration, Time to Heal the Schism, along with board members Katrina Hedberg and Tom Safranek and Executive Director Jeff Engel. So remember again, this is not in your book, but it's going to be Wednesday morning, 7:15, room 214, a lot of high-powered people going to be there, and Denise will be presenting on the integration effort led by ASTO and the De Beaumont Foundation and the Center for Disease Control. So that should be a really good roundtable. And so now I'd like to move on to our plenary, Public Health Epidemiology, Excellent and Traveling the Road to Even More Promise. And the plenary will be moderated by Dr. Al DiMaria, who's currently the Medical Director of the Bureau of Infectious Diseases in the Massachusetts Department of Public Health, and our current chair of the Infectious Disease Committee and a candidate for the CSTE presidency. And I wanted to give a little insight that I bet most of you know, that Al has a most wicked sense of humor. You would never know that. And he also has been on so many expert committees and knows so many people that if you just want anyone in the world to come and speak, just ask Al and he'll personally write a little love note. So I want to thank Al for working for CSTE, because the amount of information and contacts that he brings to the table are just immeasurable, and his sense of humor is really wicked. So take it away, Al. Thank you very much.
Is that better? Oh, good morning. It's my privilege to introduce the primary speakers today. And it's a special privilege to introduce Dr. Richard Platt, because he is a visionary who's inspired me for many years. He's the head of the Department of Population Medicine at Harvard Medical School, which is unique even for Harvard Medical School. It's a joint venture between the medical school and Harvard Pilgrim Healthcare Institute. And in that role, he has been a promoter of the focus on population medicine that what we would now call the Accountable Care Organization has. But also in his role in terms of hospital epidemiology, he has made some enormous contributions, not the least of which is training and mentoring whole generations of some of the most productive people in hospital epidemiology over the years. He has also been, from the standpoint of the Department of Public Health in Massachusetts, an incredible partner in terms of many productive programs and projects over the past 20 years or so. Actually, I have a historical picture that I can show that sort of makes sort of the point about this is from about 30 years ago, and you can see Rich Platt there. The tip-off is a bow tie, which is a hallmark. And this was from about 30 years ago, and I want to show it because in that front row are three sort of giants of medicine and public health. On the, well, I can't see it there. On the right is Ed Cass, who was the founder of the Channing Laboratory. And just like the Department of Population Medicine at Harvard Medical School, it was an incubator for scientists and epidemiologists for many years, including Rich Platt, who trained there when he was at Boston City Hospital. And then in the middle is Maxwell Finland, who I don't think anybody can argue was the founder of hospital epidemiology in the United States. And again, Rich has sort of continued the work started by Maxwell Finland. And then at the other end is David Rutstein, who probably isn't as well known, but actually through the 1930s, 40s, 50s, and 60s, he was a leader in terms of what the health maintenance organization could do from a population medicine standpoint and what medical records could do besides just track individual patients in their personal care. And that very directly relates to, and I was there because I was Dr. Finland's chauffeur at the time. So what Rich is going to talk about today is very much in that vein, how we can leverage what's going on in healthcare delivery to serve public health. Please welcome Dr. Richard Platt.
Well, thanks very much. I'm a wannabe public health person, so it's a real honor to be able to join you here and to talk about some of the work that we're doing. Just about everything I'm going to be talking about for the next half hour is the product of conversations that Al and I have been having for at least a decade and a half. About a variety of topics, but the thing that we invariably return to is the notion that the clinical delivery system develops an enormous amount of information that should be of great use to the practice of public health, and that if we're creative enough, we should be able to make use of that data. Now, Yogi Berra said, in theory, there is no difference between theory and practice, but in practice there is. So while it should be perfectly straightforward to make good use of electronic health record data, in fact, it's taken a fair amount of work to do that. By way of setting a background about what the opportunities should be, let's just reflect a second on much of the practice that goes on now. This is a list of infectious and communicable diseases that Massachusetts providers are expected to report to the Department of Public Health, and I draw your attention to this statement that reports should be made within 1 or 2 business days. So how do providers do on meeting that standard? Well, they have to find a case report form if they're going to do that. This is an example of the Chlamydia case report form. It has a couple of dozen data fields. It's as easy to fill out as a full-page form that has a couple of dozen data fields should be. It requires somebody with a fair amount of sophistication to transcribe, to find that information in a medical record and then transcribe it. And then you'll see it should be faxed to a number at the health department. As a result, clinicians in Massachusetts are not appreciably better than reported in the literature. This is data. Thanks. This is do this or something if I'm coming across garbled. This is data from the literature on typical reporting delays. You can see for 3 high-impact public health problems that the reports are typically received 2 to 3 weeks after diagnosis is made, typically well after the most important opportunity for intervention has already passed. Well, the news is even worse than that because, in fact, those are the reports that are received. It turns out that only a third of cases of pertussis and hepatitis are reported at all, and about half of cases of salmonella. The goal, of course, is to have complete reporting and to have it with no delay. And the question is how to do that. There has been a move toward electronic lab reporting for very, very good reason. And in fact, electronic lab reporting makes a big difference. Here's a report from the literature showing that on average, the time to reporting is reduced by well over a week, and the number of reports that are submitted increases by several-fold. In Massachusetts, that turns into a couple of 100,000 reports of hepatitis, 35,000 reports of sexually transmitted diseases, and about 38,000 cases of enteric disease every year. So that's certainly good news. What's not so good about it? What's not so good is it's not possible to distinguish often the acute cases from chronic cases. It's not possible to identify among these very large number of cases the relatively small number of high-risk cases, for instance, women who are pregnant or individuals who have not received indicated therapy. And it's not so easy to identify the clinician who provided care, and it's certainly not easy to make contact with the individual, him or herself, about whom the information is being reported. And so our goal in the work that we've been engaged in for quite a few years now is to try to create the best marriage of the kind of information that can come out of electronic lab reporting with the very rich historical and contextual and clinical information that is supposed to be part of typical now paper-based reporting. We're also interested in applying these kinds of techniques to improving the surveillance of non-infectious diseases and to be able to complement the kind of information that's developed through surveys of the population or through direct outreach or examination and laboratory testing as reflected by the behavioral risk factor surveillance study or the very impressive NHANES work. Our goal is not to replace these, but to be able to make available information that now exists in electronic health records regarding behaviors like smoking, information about the blood pressures, the body mass index of individuals who live in communities, and to do it in a time frame that can make it useful for intervention. So we're doing that through an activity that we call ESPnet. ESPnet stands for for EHR support for public health. There are three goals of ESPnet. The first is to identify conditions of interest. The second is to create complete reports of all the relevant information that's in an EHR, and then to transmit them to the health department, and to do that in a way that is essentially invisible to clinical providers. We want to do that in a way that is compatible with any EHR that can export data, to do it in a way that's compliant with national standards, and to do this through open source software. Our partners in developing this are the Department of Public Health in Massachusetts, my own Department of Population Medicine, the eHealth Institute in Massachusetts, as well as 4 main clinical practice partners. There are 5 installations of ESPnet. 4 of them are in Massachusetts, and 1 is in Cleveland. In Massachusetts, we fly under the banner of MD-PHnet. If, as a result of conversations we might have over the next weeks or months, you develop an installation in your own area, I encourage you to find your own name for it. At a cartoon level, here's what happens. Every night, the EHR system downloads a record of essentially everything that happened during the preceding day. Almost all of the coded information that are diagnoses, laboratory tests and test results, medications prescribed, vital signs, and demographic information is downloaded to a server. This server transforms the data into a standard format, does some quality checking, and then runs a series of algorithms to identify cases of interest when it finds them. It puts them into a format that that the Department of Public Health specified. It's an HL7 message that goes to the health department. I want to spend a minute describing why we use this decoupled architecture, where the data moves out of the EHR into ESPnet. But before I do, I'll say that this data stays behind the practice's firewall, so that there's a high priority on ensuring that protected health information stays where it belongs. And so sometimes this is a physical server. Some practices used cloud-based EHR record systems, and then the ESPnet server is a virtual server in the cloud with their data. The reasons we do this are we want to build one system that can be compatible with multiple EHRs, and by taking the information out of the EHR, it makes it simplest to do that. The second reason is we recognize that the clinical informatics departments that are charged with making EHRs work are fully busy keeping those systems in shape to serve the clinical practices. And so we want to take essentially all those responsibilities away from them, just because it can't be a priority for them. We also don't want to burden the actual computing system that supports the EHRs. We found that some of the applications that we have are capable of slowing down a clinical system, and that obviously is intolerable to the practice. And finally, we want to make sure that the clinical practice is assured that it has complete control over the access to its data and the way that those are used. I mentioned that the data are transformed into a standard format. That's a series of flat files. They're very, very simple files. They're all linked together by a single person ID. There are two kinds of data. The 9 tables that I show here are attributes of the individual, and they are linked to another series of tables that are attributes of every visit. And so the combination of the person-level data and the visit-level data allows us a fair amount of flexibility in terms of understanding what the person's history and status is. So let me describe to you how we use this data to identify cases. All of this information goes into the mix, and we found that we've had to develop a series of rules for identifying the cases that we care about. Sometimes these cases are very easy to identify. A case of chlamydia is identified by a positive chlamydia test. If you know which chlamydia tests are being used and can identify them in the EHR data feed, then that's a direct transform to a case report. On the other hand, a condition like acute hepatitis B took a fair amount of work between us and clinical experts who sort of understand the presentation and management of hepatitis, and the people who designed our EHR system. So here was a first attempt using ICD-9 codes to identify cases of interest. It would stand to reason that 070.3, viral hepatitis B, would be a good code to look at. In fact, when we went back and reviewed 50 patient charts, none of them, in fact, had acute hepatitis B. The second approach is to do a version of what the ELR would do, and that is to look at most recent laboratory tests and combine the requirement for abnormal liver function tests with a positive hepatitis B surface antigen, and that does pretty well. The positive predictive value is about 50% there. But the real strength of the EHR is the ability to look back as well as to tell what's going on now, and by combining both current and past laboratory tests and ICD-9 codes, it's possible to do pretty well. This is an algorithm that requires all 5 of these conditions to be present, and they include things like no positive prior hepatitis surface antigen test. no ICD-9 code for chronic hepatitis ever. So when you put these together, in fact, the positive predictive value is 97%, the sensitivity is 99%, the specificity is 94%. These data were developed, this was developed using a data set that spanned about 15 years. When we applied it to the next several years worth of data, it identified about 2,600 positive tests. That represented 600 individuals. In principle, you could do this with an ELR system. What ESP was able to do is to break those 601 down into 593 that were chronic cases and 8 that were actually of interest for reporting. And so by dint of a fair amount of work, it was possible to develop an algorithm that now runs every night and looks for new cases of hepatitis B. We believe that this is something that can be used in a variety of settings. I want to show you one more example, and this is one that uses the drug prescribing information along with lab test orders and ICD-9 codes. And this is the algorithm for identifying cases of active tuberculosis. Turns out we're unaware of any use for pyrazinamide other than treating suspected active TB, so that by itself counts. The prescription of 2 or more medications typically used to treat tuberculosis plus an ICD-9 code for TB within the next 60 days has high predictive value. And an order for an AFB smear or an AFB culture plus an ICD-9 code also has high predictive value. Putting these 3 together proves to have very high sensitivity for identifying cases of active or suspected tuberculosis, which is the group that are supposed to be reported. And of course, this will find culture negative cases that ELR can't find. It takes a fair amount of work to develop and validate and then certify for reporting each of these conditions. And so we've been munching through these one at a time with our colleagues in the health department, identifying the conditions with the highest valence for them. We're currently reporting these 8 conditions. I'd like to switch now to talk about what do you get for having these up and running. The reports, I just want to remind you that the reports we submit are HL7 formatted messages that have these 6 categories of data elements, identifying information about the patient that's name, age, race, address, telephone numbers if they exist, information about the clinician and contact information for the clinician. The basis for the report, what were the patient's criteria that satisfied the case definition, treatment that was prescribed, symptoms, and if relevant, pregnancy status. For each of these conditions, when we compared the reports coming from ESPnet to manual reporting, which for much of this period was done concurrently, there was better performance, meaning more case reports from ESPnet than from the manual system. The ESP reports are next day reports. ESP also typically provides complete reports. This is showing pregnancy reporting status for women with chlamydia or gonorrhea. You can see that the manual reporting system reported that about 5% of the time. As a consequence, ESPnet was noted that 13% of women with these conditions were currently pregnant, as opposed to 1% of the manual reports. The manual reports did a pretty good job of reporting treatment status, but not as complete as ESPnet. And we identified that manual reporting resulted in some error in the patient's name in 6% of cases, whereas ESPnet doesn't have a choice but to report the name of the patient as it appears in the medical record. So our sense is that for the conditions that are reported, the timeliness and the quality of the data is good. I'll just mention again that all of this reporting is done in a way that is invisible to the clinical delivery system. Neither the neither the clinicians nor the clinical IT staff are involved in any of the reporting that I just described. Having set up the system, there are a number of additional ways in which we can use the data. A couple of years after we set up the individual notifiable disease reporting, we began syndromic surveillance reporting for influenza-like illness. This shows the very familiar pattern of influenza-like illness. We basically put into code the Sentinel reporting system. This runs every week. There's no extra labor for any of the clinicians. It comes from a population of that's a little over 10% of the population of Massachusetts. It's incorporated into the state's reports to the CDC. My understanding is that this is the largest single contributor to the state's reporting of influenza-like illness. We have turned our attention recently to identifying chronic diseases and non-infectious conditions, putting our major energy first into being able to identify and therefore monitor diabetes in our population. We used the same kind of approach in developing the criteria for identifying the condition as I described for hepatitis, and at the end of the day, we have an algorithm that performs well by looking for one of these three kinds of laboratory tests: glycosylated hemoglobin, a fasting glucose, or a random glucose exceeding certain levels, multiple diagnoses of ICD-9 codes for diabetes, or prescribing of certain medications. Just note that it's not the prescribing of any oral hypoglycemic because, for instance, metformin, which is very commonly used to treat diabetes, in fact, is also used to treat metabolic syndrome, and we didn't want to identify that. So it was important to do a fair amount of work to eliminate those kinds of false positives. This was a fair amount of work. It took even more work to come up with a clean way to distinguish type 1 from type 2 diabetes. And we have an algorithm that works pretty well now at that. Among patients who have frank diabetes, to be able to, they are almost always type 1 if they meet any of the 5 conditions on this slide, and if not, they are part of the 90% of people with diabetes who have type 2. Now, everything I've described so far is reporting that, in a sense, originates from the practice and is delivered to the health department. But there are situations in which the health department wants to initiate queries for something that isn't a standard report, or that can be something about a condition that's currently being reported, or it can just be a new question. And so we have built the capability for the health department to be able to initiate queries. Those might be queries about asthma or infertility or screening rates or wanting to know about the blood pressure. The way we do that is through the implementation of a distributed data network. An authorized user can compose and submit a query through a secure portal that goes to each of the participating practices. The permissions are set up so that the practices can receive and review every query, know what it is, and make a decision on a case-by-case basis if it's willing to execute the query. When I say query, I mean a program that can be executed on the underlying data set. It's not a question. It's not an English language question, and we typically do that as SQL or SAS queries. But the result, the query is always readable as plain text, and the result is always reviewable by the practice, so it can decide whether it's going to return that result to the health department. Now, we also built the capability for non-programmer users to ask a certain set of kinds of questions using menu-driven capabilities, and it's that system that generates this kind of graphic. We call it the riskscape. It's a menu-driven system. It has drop-down menus. Here I've shown an example of selecting type 2 diabetes, and the first level result that comes out of that is a heat map, and you can see, if I can run the pointer, you can see, I'm sorry about that. You can see here that these are the areas with the highest prevalence of type 2 diabetes. Keep your eye on the same general areas, and you can see, no surprise, that those are the areas with the highest prevalence of obesity, as measured by a BMI greater than 30, and they are also the areas with the highest concentration of people who have a high measured blood pressure. So this isn't a diagnosis of hypertension. It is taken directly from the blood pressure readings in the electronic health record. It's possible to do some first cuts of data analysis to stratify by any of a number of characteristics. You see here that among individuals with type 2 diabetes who are under 40 years old, the condition is most prevalent in blacks, and that among those patients with type 2 diabetes under 40, no surprise, the condition is most prevalent among those who have a BMI greater than 30. It's possible to drill down on zip codes. This is a comparison in orange of the greater Boston population to the central Massachusetts population in blue. Hypertension is more prevalent among all races in greater Boston than it is in central Massachusetts, and it's more prevalent for all age groups in greater Boston than in central Massachusetts. It's also possible to use the same kind of menu-driven quick analysis capabilities to look at the clinical condition of patients with condition of interest. So among people with type 2 diabetes, almost 60% have high measured blood pressure, and about half of them have glycosylated hemoglobin that's greater than 6.5. We have a number of things in progress. The thing that's closest to completion is development of the capability to automatically detect and report vaccine adverse events. In order to do that, we've had to develop a couple of new capabilities. One is to be able to send messages back to the clinician to ask for additional information, and we do that by creating a secure link out of the EHR system. And then we've developed the capability to put reports back into the EHR. So just to show you how that works, this is the diagram we saw before of data going from the EHR into the server. But now the server can put a request for information back to the clinician that looks something like this. Dear Dr. Jones, your patient, Bob Wiggins, might have had an adverse effect of a vaccine. He developed meningitis 7 days after measles vaccine. If you think this might be a vaccine adverse event, click the lower right box, and a report will go to the CDC VERA system. There's a space here for you to add any free text that would provide context that you think is important for the VERA system to have. The clinician responds typically by just clicking submit or decline if the clinician thinks that it's not a vaccine adverse event, and then the server puts a report in the EHR and sends off an HL7 message to the VERA system. Things that we are committed to do but haven't started yet are to obtain certification for meaningful use stage 2 ELR reporting, and to be able to monitor the response to a community-focused obesity prevention program, to be able to compare the measured BMIs in communities where the intervention is taking place to other communities where it's not. Things that we're eager to do if we can find the funding include creating the capability automatically to scan the records to identify situations in which individuals who are known to have conditions of interest who should receive follow-up or treatment aren't documented to have that treatment. And so to be able to reach out to a designated individual in a practice or in the health department about overdue tests of cure for STDs or overdue glucose tolerance tests for postpartum women who have been noticed to have gestational diabetes, meaningful use stage 3 certification, and we believe that the system can actually be useful for other purposes such as supporting practice-based research, comparative effectiveness, clinical trials, and the like. I'll close by by pointing out this statement that is now 100 years old and appeared every week in public health reports for several decades. No health department, state or local, can effectively prevent or control disease without knowledge of when, where, and under what conditions cases are occurring. Our intent is to try to bring the great wealth of information that is in electronic health records to the service of public health, the public health community, in order to be able to take effective action to improve the state of public health. I mentioned that this is an open source program, and the source code and documentation are available on our website. We would very much like this to be a collaborative activity. There's much more to do than we have capability to undertake, and to the extent that we could partner in doing this work, we would see that as a great advantage. And so I hope that this is the beginning of a conversation about ways we could work together to identify new potential uses and to build capabilities that all of us would be able to use. I want to acknowledge the contributions of a very large number of people, only some of whose names will fit on this acknowledgement slide, but this has been the work over years of a large number of committed people who have been working to try to make it possible to do something that seems perfectly straightforward. And I'll thank you for being attentive.
We do have some time for a couple of questions. If people can go to the microphones to ask their questions or comments. In the meantime, Dr. Platt will be available at 12 noon in room 211 if people want to discuss the application and the potential utilization of ESPnet further. So people are welcome to come to room 211 at 12 noon, which is, I think, between scheduled events, to discuss that with him. We have a question over here.
Yeah, John Raisler, Minnesota Department of Health. I work in injury and violence prevention. Just interested, have you thought about gunshot wounds using the EHR? Gunshot wounds or traumatic brain injury, a couple of things I do surveillance on that, boy, would I like that info.
Yeah, so I agree. You know, so the short answer is yes, it should be possible to identify a wide array of things as long as they make their way into the EHR. So the short answer is should be possible.
Denise?
Hi, Rich. This is Denise Koo, CDC.
Oh, hi, Denise.
Hey, Rich. It's so great to see all the work that you've done and the progress that you've made over the years. And I was just wondering, it's great to talk about making the code available. I was wondering if you have any examples of, because I saw some collaborators in Ohio, et cetera, of other places where they are trying to use the resources that you're making available, because I think the question that probably is often on the minds of various health departments is, yeah, that's great, but you're in Massachusetts, so how do other people sort of take these kinds of resources and use them, and do you have any examples?
The non-Massachusetts example is Metro Health in Cleveland, where a very interested chief medical informatics officer was the champion who made that work. One of the things that we've been trying to do is to just make it easier to implement this, because and our current thinking is that this is one of the many kinds of things that probably make sense to outsource. I mean, it depends what the informatics environment is that a practice lives in, but in the make or buy decision making, my sense is for many organizations it probably makes sense to contract with people who have experience doing this kind of thing. I mean, I don't set up the new TV in my home, and maybe it's the kind of thing that you'd like somebody who actually does it for a living to make work. I think what's absolutely essential is a health department that can clearly articulate what its priorities are, and a willing practice that has what for now has to be a sufficiently large EHR to make it worth sort of creating the necessary infrastructure.
One of the things that we plan to do with the EIS surveillance course this year is try to start asking the EIS officers to ask the questions whether the case definitions are more machine-friendly.
Jenny, 2 more questions?
Sharon Oliver Price from New Hampshire. So I actually have 2 questions, but they're probably quick. Providers in Massachusetts, are they all part of the system or just selected providers, and how do you engage providers to provide this information? That's one. And the second thing, I think it's very easily explainable that you provide information about reportable disease that you have to, but how do you convince providers to provide data on things that they're not supposed to, like BMI and smoking? And is there any pushback about privacy of patients? You have data on census tract level.
Right, so I'm sorry, the first question was?
Who is involved in the network from Massachusetts?
I'm sorry. There are 4 practices or communities in Massachusetts that do this. Altogether, and they're by design large practices. So it's a large multi-specialty group practice that cares for 700,000 patients. It's the Mass League of Community Health Centers that cares for about 400,000 patients. The Cambridge Health Alliance that cares for 300,000 patients. So all told, that's about 20% of the population of Massachusetts is covered by just those practices. The practice leadership has to make the decision about whether it's willing to participate, and then the clinicians know about it, but they actually don't think very hard about it. The information about whether to provide information about the non-reportable diseases is actually pretty straightforward, because that's not individual level reporting. It's not as though there is a report that goes to the health department about each individual's smoking status. That's all aggregate information that's at the level of zip code. And so in fact, the issues about privacy have really been dealt with by that sort of privacy preserving characteristics. Okay, and part of the way to get buy-in up front is by saying to the practice, you have complete control over all the information that's in your EHR and can decide on a case-by-case basis whether to respond or not.
Thank you.
Last question?
Megan Davies, North Carolina. I have a comment and a question. My comment is, in one of your slides you mentioned using the EHR as a source of information. We now look to BRFSS and HANES to understand at a population level some health risk behaviors and chronic disease issues, injuries, things like that. And coming from a state in which our legislature and our governor have chosen not to expand Medicaid, I think that makes a difference in your ability to look at EHR to understand those things. In Massachusetts, where most of the population actually has health care coverage, the chances that it's going to be in a medical record are much higher than in some of the states that aren't doing that right now. But it's a very intriguing and appealing thought.
Yeah, I just want to be very clear that I'm not suggesting this kind of EHR reporting as a substitute for true population-based surveillance of health states. That is invaluable information. I see this as a complement, available in some ways available for a larger fraction of the population, even though it might not be a representative one, and typically available on a shorter time horizon. The BRFS data is typically published a couple of years after the surveys take place, whereas if you'd like to know whether the community obesity intervention is having an effect, you'd like to be able to see that information unfold sort of as the intervention is ongoing. So it's that kind of complementarity that we're really aiming for, not to suggest that it's time to scale back either BRFSS or NHANES.
It's also more objective than somebody's stated weight on an interview. But The question is, how much work does the practice have to do? You said it's transparent to the clinicians,
Yep.
but presumably their IT staff have to spend some of their time working on this, which wouldn't be a priority compared to the other activities.
Right, so there's a non-zero amount of setup time to get it up and rolling, and then somebody has to be around when the feed breaks or when something else changes. So it's not zero, and even if you're going to outsource as much of it as you can, somebody who actually works inside the system has to spend time with the IT group to whom you would do the outsourcing. So it's not no work, but it's designed to be as light a touch as possible.
Thank you.
Sure thing.
So if people would like to discuss using EHR for surveillance in general or ESPnet specifically, 12 noon in room 211, Dr. Platt will be there for that discussion. It's added on to the program. I have one announcement before we move forward. For the run tomorrow, which starts at 6:30, correct? You'll meet at Moringa and Green, which is an intersection here in Pasadena, which is sort of, which way? That way. In front of Starbucks. Everybody knows where the Starbucks is by now. And there'll be a pacing flag. So 6:30, Moringa and Green. And again, it's a privilege to introduce our next speaker as well, who has made an enormous contribution to healthcare-associated infection in relation to CSTE's activity. Marion Kainer is the director of the healthcare-associated infection and antibiotic-resistant programs in the Tennessee Department of Health. She she went to medical school at the University of Melbourne and trained in internal medicine and infectious disease in Melbourne, became very interested in healthcare-associated infection and epidemiology, got her MPH at Monash University, and then worked for the State Health Department in Australia. And then, fortunately for us, she decided to come to the United States and be an AIS officer in the Division of Health Quality Promotion at CDC, and then stayed on in the Tennessee Health Department. Last year, she was a recipient of the Distinguished Leadership Award, even before the situation that she's going to talk about today, and was Person of the Year in Tennessee last year for the work that she did related to the fungal meningitis outbreak, which I have to have some guilt about because I'm from the source state, and there'll be no making up for that. Sorry, it's just a really terrible circumstance. And to share the experience with us is Marion Kainer.
Thank you. It is an honor and privilege to be able to speak to you today in beautiful Pasadena. On Tuesday, September 18th, the Tennessee Department of Health, or TDH, received an email from an astute clinician. The email describes a middle-aged, immunocompetent man with Aspergillus fumigatus meningitis and a small epidural abscess who received a lumbar epidural steroid injection, or ESI, at an outside facility. Within 48 hours, we confirmed the procedural details, contacted CDC, and identified 2 potential additional culture-negative cases of meningitis. The Clinic A, closed voluntarily. Medications and supplies were sequestered, including preservative-free methylpenicillin acetate, or MPA. We traced the MPA to New England Compounding Center, or NECC. Hearing that a compounding pharmacy was involved set alarm bells ringing. In 2010, TDH investigated a cluster of endophthalmitis cases and implicated a compounding pharmacy that was repackaging Avastin. We also were aware of 2 reports implicating contaminated steroids supplied by compounding pharmacy. One resulted in fungal infections, the other in serratia or bacterial infections. Within 72 hours, we completed an on-site evaluation of clinic processes and the environment of care. There was no evidence of construction or water damage. CDC was not aware of any similar cases at the time. Via the Tennessee Health Alert Network, we asked hospitals to report meningitis cases following epidural injections. We identified additional potential cases, including patients presenting with strokes. Within 7 days, we had worked with the clinic to start contacting patients. At this stage, we had identified 7 patients with meningitis, 3 of whom had strokes, all in the posterior circulation territory. 1 patient with posterior circulation stroke who did not yet have a spinal tap, and 1 patient with cauda equina syndrome. All patients were exposed to preservative-free MPA at Clinic A. We started a formal analytic study and performed chart abstractions. Of note, several cases had undergone multiple procedures. We participated in a conference call with our CDC and Massachusetts Department of Health partners, as well as NECC. NECC indicated that they had not received any adverse event reports. There had been no change in procedures and no new supplier of the active product ingredient or API. To facilitate targeted case finding, we requested a distribution list of consignees. We described the severity of cases to NECC and that MPA was by far the leading hypothesis and that all other possibilities such as needles and syringes were far less likely. We provided NECC with the 3 lot numbers that we were concerned about and verified that NECC had recall procedures in place. The following day, Wednesday, September 26, we alerted the public health community via EPX. We asked that cases of clinical meningitis or other neurologic infection with onset within 1 month of epidural injection since July 1st be reported to us. NECC performed a voluntary nationwide recall of 3 lots of MPA, which were the only lots ever linked to the outbreak. NECC also provided the distribution list of MPA, which we had requested to perform more active case finding. A total of 17,675 vials of preservative-free MPA from these 3 lots were shipped to 76 facilities in 23 states. Tennessee received 2,520 vials. 2,000 went to Clinic A. Clinic A received the largest number of vials in the US. Another Tennessee facility received 300 vials, the other 220. There was a very strong sense of urgency which resulted in multiple parallel efforts that included chart abstraction, database construction, data entry, preparation of SAS code, as well as active outcome ascertainment through patient outreach. This was a labor-intensive manual process. We collected data on 306 patients who underwent 586 procedures in a newly created database within 60 hours. Our data collection form collected patient demographics. Procedural level data included operating room times, staff, doses of medications, anatomic location of injection, and injection approach such as translaminar. The translaminar approach is shown here in red, the transforaminal approach in green. We embarked on a cohort study rather than a case control study, as this outbreak was evolving very rapidly and many non-cases were becoming cases. Lot numbers of medications were not recorded in patient charts. In order to allocate lot numbers, we had to capture type of steroid and dose administered on a daily basis. In addition, we could calculate attack rates, which were important for risk communication and prioritization of patient outreach. Within 9 days, or 60 hours from embarking on the cohort study, we had the first preliminary results. At this stage, outcomes were known on 181 patients. No clinic-related factors were identified. However, MPA was implicated. As you can see, the relative risk increased to 1.9 and 2.7, depending on the cumulative dose of MPA received. Additional details on the early steps of the outbreak investigation in Tennessee will be presented by our CSTE fellow, Andrew Weesey, on Wednesday during the There Is a Fungus Among Us session. Jennifer Ward will present on surveillance, data management, and access to electronic health records at Tuesday's surveillance and informatics session on how information management saved lives. I strongly encourage you to attend these 2 breakout sessions that will provide greater details on the response to this outbreak by Tennessee and other states. On September 27th, we had a breakthrough that confirmed that this outbreak was not confined to Clinic A. North Carolina reported a potential case of meningitis. The patient developed a posterior circulation stroke the following day. They were exposed to one of the 3 recalled lots of MPA. They also shared other exposures with Tennessee cases. The lidocaine was from the same lot and manufacturer. Povidone iodine from another manufacturer supplied the North Carolina and the Tennessee clinics. We gained a better understanding of a spectrum of clinical presentations, some of which were subacute, ranging from few objective signs. Objective fever was present in 8% and meningism in only 15% of cases, to devastating stroke and Calder-Equina syndrome. At that stage, we had the results of the index case who was culture positive for Aspergillus fumigatus and galactomannan or antigen test positive. All our cases at this stage with lumbar punctures had a high protein, low glucose, and high white cell count in the CSF. However, all other tests, including antigen tests, were negative. We asked CDC if any molecular tests could be developed. Despite the negative fungal culture and antigen results, we still felt that the clinical picture was consistent with fungal meningitis. The posterior circulation stroke syndrome was suggestive of an angioinvasive fungus such as Aspergillus or Mucor. We had great concerns that patients may not seek care because symptoms were so subacute, and physicians may not perform spinal taps, order fungal tests, or start empiric treatment with antifungals. Once the exposed cohort was identified that included over 1,000 patients in Tennessee, 2 resource-intensive outreach efforts were initiated by the Tennessee Department of Health in collaboration with the 3 clinics who administered the steroid injections. The first outreach effort was for case finding and follow-up. The second outreach, conducted after Thanksgiving, was performed to identify patients with local infections. A large group of public health staff were mobilized to complete this effort. Local and regional public health nurses tracked down patients, knocking on doors, collecting information, and providing education. We even had to track down a tour operator in Yellowstone Park. The Tennessee Countermeasures and Response Network, or TNCRN, patient tracking module was deployed to assign and track patients for follow-up and facilitated communication on case and follow-up status between the State Department of Health and the local and regional officers in the field. Having a system that was already in place and that regions were trained in using enabled us to follow up on all exposed patients and assure that no one was missed. Use of a TNCRN application will be discussed in the surveillance and informatics session on Tuesday. On Wednesday, you have the opportunity to hear the perspectives from Virginia and New Jersey and Florida's experience in using syndromic surveillance for case finding. Meanwhile, in Tennessee, we wanted to calculate attack rates for different lots of MPA. However, as I mentioned, lot numbers were not recorded in patient charts. We knew the earliest date a lot could be in use from invoice dates. We derived the number of vials used for any procedure from the dosage recorded in the chart. No vials were shared between patients, and we knew the number of vials on hand. The clinic utilized a first-in, first-out policy, and wastage was rare. So we walked back and assigned lot numbers until all vials were accounted for. We requested a clinical epi-aide with an infectious diseases trained epidemic intelligence service or EIS officer to assist in chart abstraction to describe the clinical features of cases, including incubation periods. This was complex because it was often difficult to nail down the exact date of onset of symptoms as patients received epidural steroid injections for pain. In addition, patients frequently underwent multiple procedures, and it was difficult to determine which exposure was the one that resulted in infection. On October 1st, or day 14, TDH held its first press briefing. Daily press briefings were held for the first 2 weeks and then slowly tapered off. In our press briefings, we were conscious of the 4 factors that determine whether a messenger is perceived as trusted and credible by the public. On October 3rd, or day 16, CDC published the first interim treatment guidance. We also had another major breakthrough, our first confirmation that we were dealing with a fungus for histopathology of a biopsy of a piece of dura that had enhanced on imaging. This fungus appeared to be invading across tissue planes, but did not look like aspergillus. Histopathology and autopsies provided much needed information in this outbreak. This required intense collaboration with surgeons, OR staff, pathology departments, the Office of the Chief Medical Examiner, county medical examiners in Tennessee and across state lines, our state public health lab, the CDC, narcotics and infectious diseases pathology branches. On October 4th, the state public health lab from Virginia isolated and identified Ixorilum rostratum, a black mold from the CSF, as part of an unknown death investigation. That patient was subsequently determined to have been exposed to one of the 3 lots of preservative-free MPA from NECC. Ixorilum is an environmental fungus. There were only rare case reports of human disease and no reports of meningitis. That same day, FDA announced that they had observed fungal contamination by direct microscopy from a sealed vial of MPA. And CDC activated the Emergency Operations Center, or EOC, with a series of strategic objectives listed on the slide. I will briefly touch on some of the advanced testing that took place at CDC laboratories. The Narcotic Diseases Branch developed a PCR test within 2 days by modifying a commercial kit designed to concentrate viral DNA in human body fluids. This was used to test a very large number of specimens in a short period of time. Diagnostic and treatment guidance was essential. The clinical challenges from this outbreak existed at all response levels. As soon as patient notification efforts were underway, thousands of patients were seeking medical care. Many physicians had never seen or treated fungal meningitis. Also, because all patients were being given steroid injections to relieve existing pain, it was often difficult to distinguish new symptoms from baseline symptoms. Finally, diagnostic tests such as lumbar puncture were not without risk. In order to help clinicians around the country who were on the front lines of this outbreak, CDC engaged clinicians with experience in fungal infections for a series of discussions to establish the best practices for diagnosis, treatment, and management of these patients. This resulted in real-time development and dissemination of guidelines for patient care that evolved with a constantly changing outbreak. The Centers for Medicare and Medicaid, or CMS, have been a great partner in this outbreak. They worked to remove prior approvals and any other barriers to expedite treatment for patients. Early on, CMS reached out to America's health insurance plans and communicated the serious nature of this outbreak and noted what CMS was doing to ensure access to treatment. Meanwhile, back at TDH, as the number of cases increased, the Healthcare-Associated Infections, or HAI team, continued to update analyses on a daily basis and communicated epidemiology, or EPI-snapshots, to CDC. This is an example of an EPI-snapshot from October 7th. At that time, we had 31 cases in Tennessee. We calculated and expressed attack rates using various denominators to allow us to assess the potential magnitude of this outbreak across the US. Attack rates for the 06 lot were 56 per 1,000 patients, or 40 per 1,000 procedures, or 25 cases per 1,000 1 ml vials. This is part of the same report showing characteristics of cases and non-cases, and for those whose outcome was still unknown because they were under investigation or had not yet been successfully contacted. And here is the analysis of the 06 lot, again showing a dose response to MPA. This figure from our New England Journal of Medicine article shows attack rate by lot number. The x-axis shows date of procedure in 5-day intervals. The right y-axis, the attack rate, corresponding to the red line. The bars show which lot numbers were in use for case procedures, corresponding to the left y-axis. Each lot number reflects the date of production and is shown in a different color. The time periods of potential lot overlap are also indicated by a different color. For simplicity, I refer to the lot number by the month of production. The number of case procedures was largest among the 06 lot, shown here in light blue. The attack rate, shown in the red line, approached 27% and increased with time among the 06 lot recipients. We hypothesized that the fungus multiplied in the vials as time progressed, resulting in high inoculums in patients injected with older vials. This is a univariate analysis of risk factors for Clinic A, showing a 19% attack rate among persons exposed to 06 lot vials of MPA that were greater than 50 days old, with a relative risk of 6.2. Here is a graphical representation of the estimated cumulative risk of fungal infection using our multivariate logistic regression model in a woman over 60 who received MPA with a translaminar approach. On the x-axis is the dose of MPA in 40 milligram increments. On the y-axis, the predicted risk of infection, and the lines in different colors represent lot numbers and vial age. The top dark purple line represents the 06 lot vials aged greater than 60 days. Exposures were often complex, involving combinations in various doses of both young and old vials of multiple lot numbers. We developed a shorthand exposure fingerprint to summarize and rapidly communicate exposure information, as shown in Meredith Canego's poster that you can see this afternoon. By October 19th, in Tennessee, we were aware of 8 deaths. 7 occurred among patients with stroke. 5 patients developed strokes during their hospitalization. 8 patients presented with posterior circulation stroke, and 4 of these had symptoms less than 48 hours before admission. The question was raised whether any additional intervention was warranted among asymptomatic patients given the very high attack rates seen among some subgroups of patients. Martin Meltzer and the CDC modeling team collaborated with TDH on a formal decision analysis to evaluate whether additional approaches were warranted. It was critical to differentiate between cumulative risk and ongoing risk. This required us to understand the distribution of incubation periods, and you already heard the challenges associated determination of incubation periods. Meredith Kaner's poster describes how TDH used the results of that decision analysis to prioritize patient outreach. Communication with the public, including patients, clinicians, or the general public, was a key aspect of this investigation. Communication strategies by CDC included electronic communication dissemination with postings on EPX, the Emerging Infections Network, Clin Micronet, and blast emails to professional societies and listservs, and frequent updates on a dedicated CDC website. 10 bulletins were released to the Health Alert Network. There were 2 webinars and 4 clinical outreach communication activity or COCA calls, which are open calls between clinicians and CDC experts that reached over 5,500 clinicians. CDC used press releases to disseminate information and provided scripts that could be used for direct patient notification. On Friday, September 28, CDC had requested that all 23 states with clinics that received the free MPA lots begin contacting patients. CDC set up a call center to assist some states in contacting patients and completed call assistance requested by 4 states by October 10th. At that stage, about 90% of nearly 14,000 exposed patients had been contacted at least once. Communication also was a key component of a response by TDH. It involved outreach to patients where public health worked alongside the clinics involved, as well as hospitals caring for patients, other states, our federal partners, and the medical community at large. We had prompt and insightful reporting by our media and had to communicate with our legislative partners at both the state and federal level. The New England Journal of Medicine paper published online on November 6 was an effort to communicate with the larger medical community. Several of our Tennessee cases were overseas when they became ill. We were asked to testify in front of the U.S. Senate Health, Education, Labor and Pensions, or HELP Committee on November 15th. So what is the current status of the outbreak? This has been an unprecedented outbreak in terms of the severity and complexity of clinical disease. The large number of exposed persons who required rapid patient identification and notification. It is the largest healthcare-associated outbreak reported in U.S. history. A total of 13,534 patients were exposed. 89% received epidural, spinal, or paraspinal injections. Nationally, as of June 3rd, there are 745 cases and 58 deaths. This map shows the case count by states, with darker green states having a higher case burden. Michigan reported 264 cases. Tennessee is the second hardest hit state with 152 cases. For 742 cases reported to CDC by May 15, 2013, 593 met a single case definition. 321 had parameningeal infection, 232 had meningitis, 33 had peripheral joint infection, and 7 had stroke without a spinal tap. 149 cases met multiple case definitions. Of those, 144 had parameningeal infection and meningitis, and 2 had parameningeal infection and peripheral joint infection. Michigan saw predominantly parameningeal infections. You can hear about their experience on Wednesday's breakout session. New Hampshire is presenting a poster on Tuesday. A large proportion of their cases involved peripheral joint infections. This epidemic curve from CDC shows the distribution of diagnoses as of May 15th. For cases who fit more than one case definition, each of their diagnoses are represented on the curve. That is, the date they were diagnosed with the first illness and the date that they were diagnosed with the second illness. Oops. Are both shown at their respective weeks of diagnosis. The y-axis represents the number of diagnoses. The week of diagnosis is shown on the x-axis from July 2012 to March 2013. A diagnosis of stroke is shown in purple, parameningeal infection in green, meningitis in blue, and peripheral joint infections in red. Early in the investigation, most patients were diagnosed with meningitis, shown here in the blue bars, and thus this outbreak was thought to primarily comprise fungal meningitis. However, as weeks progressed, parameningeal infections, shown in green, became the more common infection of this outbreak. Contaminated MPA was distributed from May 21st until it was recalled September 26th. Retrospective investigation showed that the first case patient was diagnosed in early July, although the link to MPA was not established until our investigation began. Patient notification began September 28th, and the CDC EOC was activated on October 4th to assist with patient notification and to provide resources. It remained active for 5 weeks. Cases continue to be reported. Each patient is represented only once in this epicurve for Tennessee. The arrows indicate initiation of outreach efforts by TDH. The first wave consisted of patients who mostly presented with stroke or meningitis. The second wave consisted mostly of infection at or near the site of injection. These included epidural and intradural abscesses, inflammatory phlegmons, and arachnoiditis. Most of these were identified as a result of a second round of active outreach by TDH after Thanksgiving. Note that we are still seeing new cases at this late stage. This outbreak is not yet over. The longest incubation period to date in Tennessee has been 249 days, and I'm fully expecting to see cases for a year or so. Of great concern also is that some relapses have been reported. G. Young Min's poster this afternoon provides a review of antifungal treatment regimens and outcomes, including progression of disease in Tennessee. We obtained permission from next of kin to show this picture of a gross pathology of a patient who suffered terribly from horrendous arachnoiditis that developed while on antifungal therapy for meningitis. The subarachnoid space is filled with fibrosis and necrotizing granulomas. Fungal hyphae that appear to be intact were seen within the granulomas despite 6.5 months of antifungal therapy. FDA testing demonstrated fungal contamination affecting 83% of the 08 lot and 96% of the 06 lot. Only 17 vials of the 05 lot were available for FDA testing, and those were negative by FDA. This afternoon, visit a poster from New Jersey that describes the attack rate in New Jersey by lot number. This table shows attack rate by Tennessee clinic, lot number, and vial age in 15-day intervals on a procedural level. The attack rate in vials aged greater than 60 days was over 34% in Clinic A and 36% for Clinic B for the 06 lot. The attack rate for vials aged 13 to 45 days for the 08 lot was nearly 21%. For the 06 lot, as vials became older, the attack rate increased. Bryn Berger is one of the Poster Award finalists. Her poster describes risk factors for fungal infection and takes into account lot numbers, vial age, and clinics for 3 outcomes: for meningitis, or local spinal infection, or any case meeting any case definition using the most current Tennessee data. In Tennessee, we currently have 152 cases and 15 deaths. We estimate that without public health intervention, that in Tennessee alone, we would have had 368 additional persons exposed and have seen 99 additional cases and potentially up to 69 additional deaths, all assuming that there would have been no additional shipments of MPA. This figure is from a JAMA article by Beth Bell and Rima Kabaz. On the x-axis is the week of meningitis diagnosis. The left y-axis is the number of cases. The light gray indicates meningitis cases alive at 30 days. The dark gray, those who died. The right y-axis shows the 30-day case fatality rate, illustrated by the red line. The green arrow is September 18th, when the astute clinician contacted TDH. The blue arrow, September 26th, the recall date. The red arrow is October 1st, the date of the first press briefing from TDH. The aqua arrow is October 4th, when CDC and FDA held a joint telebriefing on finding the fungus in the vials, and CDC opened the EOC. You can see the dramatic rise in the number of meningitis cases after the TDH press briefing. The red line, showing the 30-case fatality rate, initially hovered between 30 and 50%. It dropped dramatically to less than 5% and then 0%. We attribute this drop in case fatality rate to public health action that resulted in identifying patients earlier and starting them rapidly on appropriate antifungal therapy. This large multi-state outbreak required tight coordination and collaboration among public health partners at multiple levels that allowed for rapid response for identification of exposed patients, patient notification and case finding, treatment and diagnosis, and communication. Local health departments, treating physicians, and staff at injection facilities worked with state health departments and laboratories, which in turn worked with partners at the federal level, including CDC and FDA. The outbreak response was effective because of this cooperative effort. This outbreak illustrates that investments in public health infrastructure, including healthcare-associated infections, informatics, and data management, were critical for an effective response. Timely communication is essential and greatly facilitated by pre-existing relationships. It highlights the importance of astute clinician and interfacility communication. We were fortunate to establish remote data access to electronic health records that allowed us to access information in real time and relieve the burden on infection preventionists. Pre-existing relationships are key, and compounding pharmacy is complex but essential. In summary, contaminated medication was administered in normally sterile sites to thousands of people, resulting in an outbreak of fungal meningitis and other syndromes of unprecedented scope and magnitude. It demonstrated the public health impact of healthcare-associated infections and how an effective response required collaboration between the clinicians, the clinics, hospitals, local and state health departments, and federal agencies. As a postscript, NECC recalled more than 2,000 products in addition to MPA. NECC ceased operations in October and filed for Chapter 11 bankruptcy in December. A multitude of bacterial and fungal organisms were isolated from NECC products labeled as sterile, including betamethasone, triamcinolone, and cardioplegia solution. However, no outbreaks associated with other NEC products were identified. I want to thank the individuals in the organizations listed. The response to this outbreak has been a true team effort. The CDC had over 300 persons, and TDH over 180 persons participate in the outbreak response. The left picture shows the central office participants of the Tennessee Fungal Investigation Team. The picture on the right, our State Health Operations Center with our Commissioner and Governor. This is a picture of my awesome healthcare-associated infections team. I also want to thank my mentors in neurology, Ed Byrne, in infectious diseases, the late Alan Young, and Bill Jarvis, who taught me how to do outbreak investigations when I was an EIS officer in the Division of Healthcare Quality Promotion at CDC. Thank you.
Thank you, Marion, for that very compelling presentation. And we have a few minutes for questions if people want to come up to the microphones. I think many people in the room have had the experience where you're on the phone hearing a story and you get that sort of expanding vacuum feeling in the middle of your chest. And that happened a number of times in my various phone calls with the pharmacy inspectors in Massachusetts who had a substantial job. In Massachusetts, these pharmacies, compounding pharmacies, were regulated in the same way as commercial pharmacies, and we had substantial cutbacks in the department so that there were inspectors enough to generally respond to complaints, but not to do any routine inspections. So places like NECC were not inspected, even though they did not have a very good track record, and sort of were out of control by the time this happened. But I remember one moment, and that was, we were here, the executive board was here meeting in Pasadena. I got this call from the pharmacy inspector, and he said, Al, we just were looking at these vials at NECC, and we see these little black specks floating in the prednisolone. And I said, well, that's exactly what you'd see with mold growth in a liquid culture. And that's what you're seeing. And that was like the worst call. And yes, question.
David Dassey, Los Angeles County. Marion, thank you for that excellent summary. I'd like to connect what Dr. Platt talked about earlier and have your comment about how different your investigation would have been had the records at these ambulatory clinics been computerized and accessible in that manner.
It would have been wonderful. They were actually computerized, but we could not get a download or export of that function within the time period that was necessary. And so we had to manually abstract those data and re-enter those data in. But it would have been wonderful to just have a simple export function on the procedural data. It would have just made life so much easier. That was in Clinic A. The other two clinics just used paper records, and so that would not have been possible. And I had mentioned that we were able to establish remote access to electronic health records, but we could not run queries. We just were able to access them, see the information, and then do manual data abstraction from those. But that still saved us enormous time and resources and really relieved the burden on infection preventionists at these hospitals.
Yes.
Joe Purrs, DHQP. Marion, thank you again. Along those lines, do you have information as to how many Tennessee patients were hospitalized with meningitis on September 18th? In other words, getting at the perhaps missed opportunities for earlier detection and just reflections on that.
We, at that stage, retrospectively, we diagnosed, I think, about 7 patients who had had encountered the medical system. There was actually one patient who was seen. It was noted that they had an epidural steroid injection. They did an MRI scan, but never notified the facility or the health department, and the patient improved when they were given systemic steroids. And I had to trace that patient through 4 different physicians to then identify the primary care provider who was saying, she's looking fine, she's on a PICC line on systemic steroids, doing really well. And I had to say to him, I'm really concerned. You may want to consider starting this patient on voriconazole. And how do you start somebody on antifungal medication when you don't have a diagnosis? And this is horrendously expensive, so we spent about 3 hours trying to work out who was going to pay for this medication. So then making sure that CMS came to the table to ensure access to diagnosis and treatment was absolutely essential in this outbreak.
Thank you. As Marion pointed out, there'll be a number of presentations, posters at this meeting about this largest healthcare-associated infection outbreak in America. Let's thank Marion for this fantastic presentation.